Welcome everybody to our session. Today is Stop Pressure Ulcer Day nationally and internationally. So we are happy to host a small session for 30 minutes on just updating you and giving you a quick refresh on your pressure ulcer management knowledge. My name is Valerie Dowley. I'm an independent tissue viability nurse that works with OSCA in their training academy.
And I am Anita Morton. I am the clinical support nurse for OSCA.
Okay, so let's get started. I have to just move the slide along. Okay, so just as a recap, we just need to remind ourselves that a pressure ulcer is an area of localized damage to the skin or underlying tissue, usually over a bony prominence, unless it's related to a medical device, which we'll talk about in a little bit more detail. And it results from sustained pressure to the tissue. So when the tissue gets squeezed between the bony prominence and the support surface that it's resting on, obviously over a period of time that shuts down the blood vessels, it starts building up chemicals in the extracellular tissue, and there's a reduction in oxygen, and eventually the tissue will start dying off. So it can present as an area of intact skin, but obviously with redness that doesn't blanch, or visual damage to the skin, or it can be an open ulcer or a very deep wound. And they can be very painful. There are now 7 categories of pressure ulcers. So in 2018, the NHS improvement looked at standardizing the language around pressure ulcers. So we now call them pressure ulcers, not pressure damage or pressure injuries or decupitous ulcers or bed sores or whatever other names floated around. So it's about standardizing that language. So we now use the term pressure ulcers, and also about standardizing things like reporting them, defining them, and the categories. And we now have 7 categories of pressure ulcers. So the same categories we used to have: the category 1, which is intact skin; category 2, which is shallow; category 3, which is just through the epidermis and into the dermis, but not into the subcutaneous fat or muscle layer; category 4, which is the whole way through the layers of the skin and sometimes exposing bone. Then we have our unstageable, which is where the damage is covered in devitalized tissue, either necrotic or sloughy, but you can't visibly see the base of the wound, so you can't decide how deep it is, usually 3 or 4. And then there's a new one, which is called the deep tissue injury category. So there's a recognition that somewhere between when the damage was done at the deep near the bone, where the bone was pressing on the tissue, and before that damage completely died off and became necrotic, there was this period of time when that tissue was really struggling, and it manifests itself visually as something that looks like a bruise. So it's a kind of a purple, maybe slightly mottled area, looking like somebody has fallen on their bottom and got a really good bruise. And it does allow for, early intervention might actually mean that it doesn't go completely necrotic. It might reduce the severity of the damage. So that's deep tissue injury. Excuse me. And then the 7th category is around medical devices, when we provide devices to patients for their treatment that have the potential to cause damage. So we'll talk more about that in a little bit. So we're basing this around the asking model. The asking model is, again, part of that national health improvement drive to standardize things. And it's where there's a framework set in place that help us to not only provide education like we're doing today within a framework, which means that everybody ends up getting a very similar education. It also helps to look at the key factors that for patients who are under risk of developing pressure ulcers, and helps us to create that framework for care planning. So it's assessment, risk assessment, skin inspection, looking at the support surfaces we use, keeping our patients moving, looking at moisture associated skin damage, looking at hydration, nutrition, and giving information. So let's move on to that assessing risk. So we need to remember that the reason we do risk assessments is that we want to be able to identify early those patients who are at risk of developing pressure ulcers. And by catching them early, we are then able to put in place measures and care planning or even equipment that would reduce that risk for them. We do this in a couple of ways. The one way we all know is around using a risk assessment tool. So you might use Waterloo, you might use Braden, you might use the new Purpose T. They are tools though, so they are in part a tick box mechanism that give you an indication, a numerical indication, or even a coloured indication of where the factors that people feel are put people at risk. But it is just a tool, and so what we need to remember is that, for example, in a court of law, just using a risk assessment tool and basing our clinical decisions on just the outcome of a risk assessment tool won't hold up, because we need to remember we need to do our holistic assessment, and we need to also have our clinical judgment so that we get that umbrella overview of the patient, because we all know patients can have a low risk assessment but still be at a higher risk when you look at all the other factors. So some of the other factors that we need to think about are, so we need to look at that holistic assessment to be able to put that care plan together. We also need to remember that risk assessment is a progressive thing. It's something that we should be proactive in. So not only do we do it when maybe patients are first admitted to our care, we need to do any time a patient's condition changes. And even if it's perceived as a small and temporary change. So for example, you might have a patient who's generally independently mobile, maybe needs a bit of prompting and stuff, but then they get some seasonal flu or they get a little bit of vomiting and diarrhea. They might come off their feet for maybe 72 hours. You might not think, oh, well, they'll be fine, they'll be better in a couple of days. But actually, even that first 24 hours pitches their risk level much, much higher. So we need to get right in there from the beginning. Once we notice that a patient's condition is changing, that they're deteriorating, or they're maybe not eating so well or moving so well, or they get a high temperature, or they get an infection, we need to be reassessing their risk. And that also helps to ensure that we use the right equipment at the right time, that we use our resources properly, and that also that we can look at patients who may be improving and reassess their risk and actually downgrade them off high-end equipment that might be costing us. So who is at risk? Well, anyone is. And really the core factor of risk for pressure ulcer injury is mobility. It's about mobility. If a person is independently mobile, then usually their risks are very low. So if they have less mobility or restricted mobility, need prompting, need encouraging, need help, or they're completely immobile, then the risk level rises. And it rises alongside other factors, intrinsic factors that such as long-term conditions like diabetes, if they've got any paralysis, if they're very elderly, or if they're very young where they can't move independently anyway, if they have things like reduced sensation, maybe some surgery, maybe they've fallen and fractured their hip, end-of-life care, if they're going through a phase of not eating or drinking very well, which we'll talk a little bit more about later, or if they're in a lot of pain. We also have to think about the psychological and social factors. Maybe they don't want to move. Maybe it's mental health issues. Maybe they're on medications that have caused them to become more lethargic or that are sleepy, and those a variety of things like that. Excuse me. Also, we need to think about that medical device side of things. So anything that we are using therapeutically to help our patients that we would consider a medical device. So think of things like oxygen mask, tubing, splints, plaster of Paris, even compression stockings, TED stockings. We know that when patients come out of hospital, often they still have TED stockings on. They mightn't have even had them removed because they've been moved out of hospital so quick. We need to think about other things, like if patients wear glasses and fall asleep in the bed, that might cause problems if they favor one side over the other. And we need to, anything really that can compress the tissue against the support surface, whether there's a bone there or not, we need to look at. We need to be reporting them as medical device injuries. So obviously our skin inspection is really important, and we need to have the baseline of a skin inspection when we're doing the initial risk assessment. Sometimes that's a patient will allow us to see the skin, sometimes maybe they don't. And obviously if they have capacity, it's their right to let you see it or not. I think the important thing about that is that if a patient doesn't want you to do a visual skin assessment, it's not just good enough to document that they refuse that. I think it's really important that we mustn't walk away from a situation like that without asking the most relevant questions. So if they say, no, I don't want to show you my skin, then it's really important to say, so, okay, so do you have any sore bits? Do you have anything you're worried about? Is there any areas that are bleeding, or do you notice anything in maybe your underpants? Is there any areas that are sore, look bruised, or that are blistered or anything like that? And sometimes when they go, oh yes, well, I did notice that my bottom was a little bit sore, they then may allow you to see that one area. But I think even if they don't at that stage and you've asked the relevant question, then you can document that, that you weren't able to visualize the whole skin, but you've asked the relevant questions. And by the time you were finished, you were happy that the patient wasn't reporting any skin problems, but that you put them down for review. And obviously you'd keep coming back to that to make sure they were okay. We must remember that when we're assessing skin, especially white or light skin, that we need to remember to do that blanching test. So, and this can only be done on white or light skin. So we need to put pressure on any reddened area to make sure that the blood supply is still there. So if you put pressure on a red area and you take it off and there's a flash of white, it means that you were able to squeeze the blood out of the blood vessel. And then when you took the pressure off, the blood came rushing back in. So the veins are all good and healthy. But if you put pressure on a red area and it doesn't blanch, it means that the blood vessels have shut down and you have a category 1. With darker skin tones, we're not able to use the blanching mechanism, so we need to use our other senses. So we need to look at the area and see if there's any color changes. So maybe the area is darker or looking a bit bruised or maybe a bit violet in color. We need to use our touch and see if there's a temperature change. So obviously if an area is inflamed, tissue that's under pressure is inflamed, it might be a little bit hotter, or if it's dead and died off, it might be cooler. And we need to use our communication, because one of the main factors around certainly category 1 and 2 pressure damages, they're very painful. So if you've ever rubbed your heel off with a new pair of shoes, you'll know how painful that is. Can you imagine that on somebody's bottom? So it's usually when the nerve endings are jumping. So pain is, through research, has been a huge predictor of risk of pressure damage and risk of deteriorating pressure damage. And then we need to remember that out of sight, out of mind. I've already spoken about this a bit with the medical devices, but things like the heels. So, make sure we're taking off shoes and socks, make sure we're taking off compression stockings. If they're in leg bandages, make sure that when their dressings are being changed, that we actually visualize the heel and make a documentation of what it was like. We can use that with a mirror and that, and again, feeling, using our senses to make sure that we're not missing anything or any area that's slight, because we tend to focus, don't we, on the bottom and the heels a lot, but we must remember, as we said, the ears or the ankles or the elbows or even, the shoulder blades, or if somebody's particularly bony, maybe the spinal column. Yeah. So, okay. Now, Anita's going to chat to you about this.
Thanks, Valerie. So looking at sort of the next S, I suppose, in the asking care binder, we're going to look at surface selection and kind of what we use and when, really. So this isn't going into a deep delve into support surfaces, but it's just to kind of give you an understanding and idea of what you may use for what type of patient. So if we look at the top of the slide there, and we can see standard pocket sprung or foam mattresses. Now, these mattresses really are the sort of mattresses that we would use ourselves at home. We go out and purchase them, we bring them back and we use them, for a period of time. But ultimately, these are not products that we would be using. They're not medical products, essentially. So we wouldn't be using them on our patients and patients who are at risk, or certainly any patient that has any risk of pressure damage. They really are suitable for those of us who are fit and well and able to move. So although the majority of you watching today probably won't see these mattresses being used in your area by any means, certainly if you're in community, you may well have patients that are on these mattresses. And actually, I suppose you need to be mindful of any patients that you see in their own home or residents being admitted into a care home that actually they have been on these mattresses potentially previously. And so actually putting them onto a pressure reducing or relieving mattress can feel quite different as well. So just, I suppose, be mindful around your potential explanation of what you're doing and why. So if we go to the kind of, I suppose, the first rung of the ladder in terms of a medical support surface, we're looking at those pressure redistribution high specification foam or viscoelastic mattresses. Now, these mattresses are high spec mattresses, and they are suitable for those who may be deemed at risk to potentially high risk from a preventative point of view. But they wouldn't be for patients that cannot move themselves, who are unable to be repositioned, or anybody who has sort of existing pressure damage. These really are for, I suppose, your lower risk patients, and potentially treatment and management up to, say, a category 2. But we really do need to check with your manufacturer guidance in terms of what product can be used for what type of category of pressure ulcer, or in terms of prevention, what type of risk can they be used for. And obviously, as Valerie was saying earlier, with assessment, you would also use your clinical judgment to make the decision as to what support service your patient would have. So if we're then looking to step up our patient further, we would look at the reactive pressure redistribution mattresses that are either, again, foam. They may also be static air, but they can also be gel as well. And these mattresses tend to be suitable for those deemed kind of medium to high risk. May have some ability to move, but it may be also that you are still needing to reposition patients on these types of surfaces, and that's okay, as long as obviously you get your repositioning regime right for the patient. But they are often used for patients that cannot tolerate a full dynamic system, so an air mattress essentially. And that might be because of the movement, it might be because they're too immersive for the patient, and that prevents mobility on an air mattress. So the pressure redistributing reactive mattresses tend to be for those type of patients. And then lastly, we have the active mattresses. You may have heard me just calling it a dynamic system. They are also called air mattresses. There's lots of different names for these type of products, but ultimately these are pressure relieving mattresses that work with a pump to inflate air cells under the patient. And as and when those air cells inflate and deflate, as the cell deflates under the patient, you are then offloading a part of the body. Coupled with that, however, is that the inflated cells do have to come up a little bit higher in pressure to support the body when those cells are deflating underneath them. So these are generally suitable for those patients who are high risk to very high risk, and patients who have got pre-existing pressure damage, usually the kind of category 3s, 4s, unstageable deep tissue injury. So you're looking at, probably a smaller proportion of the patients you'll be looking after. And like I say, those who really are high risk. So that moves us on, I suppose, quite nicely to how we keep our patients moving. So, I mean, all of our patients that are at risk of pressure damage will need to be repositioned at some point throughout a 24-hour period, unless, of course, they're contraindicated. And obviously, this needs to be individualised. It needs to be tailored to the patient. So, we can't just sort of standardise a certain repositioning regime and use it for absolutely everybody, because, obviously, all of our patients will differ. And the anatomy of our patients varies as well. So in terms of pressure build-up and offloading, we may need to think about whereabouts the pressure is being built up and how we offload and how we reposition our patients as a result. So if they are completely immobile, we might be repositioning, say, every, we standardise that, don't we, as every 2 hours, but be mindful that, it may be that if they're on the right support service, we can lengthen that period of time between just 3 hours, every 4 hours, and also think about how that might differ between day and night, because in the daytime, we may want to be moving them more often. At nighttime, we may not want to do it quite so often because we don't want to disturb sleep. Obviously, our patients need the sleep, they need the rest in terms of healing and recovery. So we may vary somebody's repositioning schedule, and that obviously will, like I said, be different from patient to patient. If our residents or patients are have reduced mobility, then we need to be thinking about how often we're encouraging them to move, and we should be encouraging those patients to move themselves. So if they're in a wheelchair, as you can see on the picture there, if they can move from side to side, or if they're seated and have the ability to be able to stand, think about all of those times in the day when we can offload, we can reposition and encourage repositioning. That's even things like toileting, walking into the dining room, any kind of movement is really beneficial. And then think about the equipment we can use as well. So if we have got an immobile patient who is bedbound, how can we use the profiling bed to actually help to adjust position and redistribute the pressure a little bit? So that might be elevating the backrest, bringing it down, elevating the knee break. Any sort of slight movement we can make coupled with the repositioning is all beneficial. So, like I said, the immobile patients, we may be thinking as a standard 2-hourly repositioning, or varying that according to patient need. And if somebody is able to reposition themselves, how often are we encouraging this? And we should be encouraging this sort of every 15 to 30 minutes, and giving maybe visual cues in terms of how often a patient should be repositioning themselves. We also need to be very mindful of things like zips and buttons and seams on clothing, and whether clothing is tight or whether it's wrinkling under their skin, and how we're going to look at maybe inspecting the skin a little bit more if that is a problem, or how we're going to try to reduce those peak pressures under things like zips and buttons. And then just be mindful of slings in terms of manual handling. So if there's a sling that's used and it's kind of remained under the patient, then how are we managing skin integrity at that point? Are we assessing, like I said, more often? Is there a way of being able to remove seams from the slings in terms of pressure? And then looking at incontinence, so incontinence is often closely associated with pressure, I think probably because of its association with the kind of sacral area and the bottom, where we may see quite severe damage from pressure. But it's also confusing at times as to what is pressure damage and what is moisture-associated skin damage. And as much as we've got incontinence-associated dermatitis here, as it's part of the asking bundle, we need to be thinking of it a little bit more broadly in terms of moisture-associated skin damage. So not only from incontinence, but potentially in between skin folds, from sweating, etc. But in terms of incontinence dermatitis occurs really because of urine and faeces sitting against the skin for too long. And ultimately, when that happens, the urine and faeces is alkaline. So as it sits against the acidity of our skin, and our skin is naturally acidic, and we have the acid mantle of our skin, which is its protective barrier to the skin. So it protects it from bacteria and toxins and obviously risk of infection. But as soon as urine and faeces sits against that and starts to break that acid mantle down by raising the pH, we then expose the stratum corneum, that top layer of the epidermis, we expose that to risk of infection. And at that point, we then get that excoriated, red, almost burnt looking skin, where sometimes it even takes the top layer of the epidermis away, as you can see in the picture there, and it can be really painful and really sore. So the differences being between pressure and incontinence-associated dermatitis or moisture-associated skin damage is more about how it looks. So with pressure damage is localized, but with moisture-associated skin damage, that's always much more spread out because moisture spreads essentially. It will also be, obviously, it will be very painful, but it will also have almost like a butterfly effect to it. So if you've got a skin fold, and if you open up the skin fold, what redness you can see on one side will be exactly the same on the other. So it, like I say, it creates this butterfly effect. So again, you won't see that with pressure damage. We can protect the skin from moisture-associated skin damage through barrier cream. So we can apply a barrier cream to the intact skin as an added extra layer and added protection, which will stop that urine and feces and potentially sweat and moisture penetrating the acid mantle. So it gives it an extra protection. In terms of incontinence-associated dermatitis, you can also, and I would absolutely advise and encourage you to do a thorough continence assessment, or ask your continence advisors for advice on that as well. Because ultimately, if we can understand someone's pattern of incontinence or why they're incontinent, what type of incontinence they have, then it can help us to then determine how we can then look to treat and support. And also toileting is one big thing we can do to help incontinent episodes. So the more we can toilet, and the better, essentially. So in terms of nutrition and hydration, which obviously leads nicely on from incontinence, obviously with all of our patients, we should be regularly screening them. So we know the MUST screening tool that we will use to assess their risk of malnutrition. And that also then helps us to understand whether or not the patient needs referral to dietitian, whether or not they are malnourished, and how we can then actively encourage to kind of balance their meals and sort of encourage them to eat regular meals. And our patients should be eating regular balanced meals. So we would be looking at using all of the food groups according to the nutritional plate, as you can see on the screen there, and also think about any extra additional snacks that people might need. But we also need to think about, maybe making referrals to occupational therapy in terms of getting the right cutlery for someone to use to enable them to eat. If they have got a pressure ulcer, is there pain or odour that is also preventing them from eating? And obviously, looking at that screening tool and assessing our patient will enable us to do that. In terms of hydration, they do advise 8 drinks per day. This is very subjective, because ultimately what is a size glass for one patient may be completely different to another. So yes, 8 drinks per day. We're looking at around about 300 mils per glass at that point. And that would equate to roughly 2,000 to 2,500 mils, which is the recommended daily intake for fluid for an adult.
Okay, so just coming to the end, and there is a question which we will come to in just a second. So coming to the end, it's around this giving information, the G of the asking. And it's not just about what we give to the patients, it's also about the information you receive. So part of the giving information is around education, like you guys joining us today to get a quick refresh on pressure ulcer management. And the research will support that. The research says that the thing that has the most significant outcome in improving pressure ulcer management and prevention is education. And that's why we do these, and that's why we do the webinars and stuff like that. But also it's about educating. We talk about educating patient. I think patient partnership in care is really important. Think about ourselves in 30 years' time. If we happen to be patients, I would like to know exactly what you're doing to me and why you're doing it. So sometimes if we take that time to explain to our patients, another piece of research says that it's okay to give a patient an information leaflet, but actually it's much more productive if we use that opportunity to actually explain the patient information leaflet to the patient rather than expect them to read it themselves. And the other part of communication is about bringing in the wider network around the patient. So, we're all healthcare professionals, and therefore we understand the language of pressure ulcers, don't we? But actually a lot of people don't, and a lot of people don't even think about pressure ulcers until one of their family or relatives get it. So it's important that they're brought in on these conversations, and it's explained to them the reasons why as well. So that's really important. So giving information is a vital part of it. Now, I'm just going to leave the reference list up for a minute while I answer a question. So a question was asked is, please can you let us know whether you can use a pillow to support a position on a tilt? Obviously, your OT in the community is telling staff that they shouldn't be using a pillow to support a patient in tilt. To me, that's not exactly correct. The whole 30-degree tilt was created around supporting a pillow down the length of the back up to the base of the spine, and a pillow under each of the legs lengthways, so that we weren't sort of creating DVTs. I think maybe some of the OTs are beginning to look at foam wedges, Anita, instead of pillows, because pillows can be of different qualities. They can be plastic wrapped and a bit sweaty. They can squish underneath the pressure and maybe not give as good sort of offloading and support as possible. So it might be worth having a conversation with the OT that's telling you that, asking her what she considers is the alternative to using something. I used to also recommend sometimes that the pillows were put under the mattress.
Yeah.
So that the whole mattress was moved over to support, because obviously there's a worry sometimes maybe with the OT that by putting in pillows, especially if they're on dynamic equipment, that we might be reducing how good the surface that they're on. So sometimes I used to encourage my staff to actually put the pillows or the rolled blankets and stuff under the mattress itself, that gently tilted them. Yeah. So that hopefully that answers your question. Obviously, if you've got any more questions, there might be a couple more there, and Emma will put them up for us in a second while, so while Anita just talks to you about certificates and slides, and we'll comment next week. Yeah, so we'll have certificates and the slides next week for you, and Anita just wants to.
Yes, so obviously this is just a snapshot of what we do at Oscar in terms of training, and we do now have our new training brochure out, which obviously if you want any further information, we can send that to you. We are going to put a poll onto the screen as well, so if you do want any more clinical training from Oscar, then please just obviously indicate that on the poll that's on your screen now. In terms of our clinical training, we do offer lots of different modules. We'll offer modules on pressure ulcer prevention with an additional wound care as well section. We offer root cause analysis training, skin inspection, asking care bundles. So there's lots of modules there that you can access. So like I say, please indicate that on the poll. I also just want to say that we do have our usual webinar coming on the 7th of December, which is on Keep Moving as part of the Asking Care Bundle. So please, as and when you get information on that, do register, and we look forward to seeing you on our next webinar. So other than that, it's just left off for us to say thank you very much for attending. I hope you've enjoyed the session, and we'll look forward to seeing you again soon.
Okay, bye.